expired. The gentleman from Louisiana, Dr. Bustani, is recognized for 5 minutes.
Thank you, Mr. Chairman. As a heart surgeon, I had the tremendous privilege of operating on thousands of Medicare beneficiaries, and I can tell you, patient by patient, perhaps better than anybody in this room, I understand the value of the Medicare program and the importance it plays in the lives of seniors, especially seniors back home in Louisiana, many of whom have very limited means and depend on this truly for their life. And I could go on and on about the quality and what we need to do to establish and maintain and strengthen a good patient-doctor relationship based on high-quality medicine while managing cost. But that's not the purpose of the hearing. We're here to talk about the financial solvency of this program and some of the things that we need to do. The Medicare actuary has been quoted as saying that the improved hospital trust fund financing cannot be simultaneously used to finance other federal outlays, such as coverage expansions, and to the extent the trust fund, despite the appearance of this result from the respective accounting conventions, meaning we can't double count. This is a real problem. And I'll tell you, as a physician who worked with many, many Medicare patients, this is a huge disservice to Medicare beneficiaries across this country. We have an obligation to fix this program and to get it right. And when I see this double counting and the fact that we're playing games with the SGR and the reimbursement structure, this is literally legislative malpractice. And then if you go on with the IPAB, this is another example of where you're going to try to keep the lid on a boiling pot of liquid. It's not really going to be in the best interest of maintaining high quality patient care between the doctor and the patient. My question is this. We know with current law we're headed toward 2024 with the insolvency of the hospital trust fund, which means Medicare, as we know it, at least that part, the hospital care, ends. Is that correct?
Well, it certainly does not have the resources sufficient to discharge its obligation.
So if we don't correct this problem, then there will not be a payment mechanism for hospital care for our seniors.
Well, I would say there would still be a payment mechanism, but it would not be able to
pay.
To pay, and
right,
on a delayed basis.
Okay.
Reduced basis.
And before we get to that point, clearly it's not a just simple situation where we get to the point and it stops. Would you suggest that there will probably be other forms of rationing for our seniors before we get to that point under current law with regard to hospital care?
In fact, it is a situation where you get to that point and fall off the cliff. Participants will be, even after the date of insolvency, entitled to the benefits that are laid out in the program. Providers may choose not to provide as much care because they will have to wait a long time or a longer time to get paid for it. But it is a situation that up to that point, everything seems fine.
And that gets us to the access problem, because that's the other side of this equation, whereby the further we go, and it seems year after year, we're seeing more and more problems with access for our seniors. So in effect, if you don't have access or limited access, delayed access, is that rationing?
Well, I would say, there's two elements of this issue. One is the sudden withdrawal of benefits that would occur in 2024. But then there's the other question of, as we constrain our reimbursement rates under current law even prior to 2024, does that have the effect of causing providers to withdraw from Medicare or go out of business? And this is obviously something we are wrestling with as trustees and the actuaries wrestle with analytically.
I think the answer is clearly yes, based on my experience in visiting with many, many physicians across this country. And we're seeing worsening access problems. I saw them back in the 90s in my own practice, where as a heart surgeon treating a patient who came into the emergency room needing emergency open heart surgery, between the cardiologist and I, we were unable to find primary care providers to help these patients with their other medical problems. And that has only gotten worse. And so we have an obligation to deal with this. And the problem I have is on the other side of the aisle, we see these characterizations that Republicans want to end Medicare. And well, the point is Medicare is ending under current law, which they've put in place. And we need to take our heads out of the sand. And I asked our colleagues on the other side of the aisle to take their heads out of the sand, as well as the president, who has deliberately ignored this trigger. We have to be honest with the American people. And we have to be honest with seniors who depend on this very valuable Medicare program and get this right. It's critically important. I see my time's expired, Mr. Chairman. Thank you.